The topic is restrictive cardiomyopathy. This is a pretty uncommon kind of cardiomyopathy, especially in the developed world. There's a decrease in the elasticity of the myocardium, and there is an impaired diastolic filling. The compliance of the uh, myocardium is reduced, and that kind of leads to restrictive filling of the left or the right ventricles. The ejection fraction is normal or near normal, and although there is a restrictive filling of the ventricles, but the ventricular function remains normal or near normal. The compliance goes down, um, and the ventricles kind of lose elasticity, this kind of stiffness. And the reason being changes in the myocardium as a result of infiltration and several other reasons, and fibrosis. But because of these reasons, the changes brought about in myocardium as in decrease in compliance and decreased elasticity, uh, the diastolic filling is reduced. And there would be an increase in the ventricular filling pressures. So at any diastolic left ventricular volume, we would see that the ventricular pressure would be above normal. The systolic function remains normal pretty much in the early stages of the disease, but if the disease is advanced and the infiltrative process, there's a progression, then there would be an effect on the systolic function. There is a biatrial enlargement, and the walls of the ventricle would be normal to thickened. The causes would be infiltrative, as seen in storage disease disorders, as in the infiltrative diseases would be like as in amyloidosis, sarcoidosis, hemochromatosis, and then inherited glycogen storage diseases, Gaucher's disease and Hurler's cardiomyopathy. And then sarcoidosis, there is scar formation that would result in restriction. And then in Loeffler's endocarditis, we would see a restrictive cardiomyopathy, and in carcinoid heart diseases, and in endocardial fibroelastosis or radiation, and toxic effects of anthracycline, in scleroderma, in endomyocardial fibrosis. Idiopathic forms exist, and of course, in diabetic cardiomyopathy, we would also see this development in a non-infiltrative fashion. Although there is a progressive left and right-sided heart failures developing, but the right-sided heart failure kind of predominates. And the person would present as edema, hepatomegaly, distended neck veins, ascites, and then weakness and fatigue and murmurs, regurgitant murmurs would be there, and as a presentation it could be there. And so the symptoms of both the left and the right-sided failures could be present, but the picture of right-sided heart failure predominates. The amyloid deposition show amyloid, which is primary AL types, and an echo would show a hyperrefractile ground glass appearance. And in hemochromatosis, there's a pretty rapid progression, and arrhythmias may occur, and sarcoidosis could show conduction disturbances. And the idiopathic forms are kind of slow in progression, and but the amyloids in folks presenting as congestive heart failure could have a high mortality. The increased filling pressures could also produce pulmonary congestion, and the X-rays would show pulmonary vascular congestion, pleural effusions, and moderate cardiomegaly. We could also see pulmonary vascular congestion with normal heart sizes on X-rays, and the reason would be that because of restriction to the filling, we wouldn't see cardiac dilation, although there is pulmonary congestion going on. So we can see that these two things can coexist, the pulmonary congestion and normal heart size on an X-ray. Echo-wise, the myocardium would show changes in amyloidosis, appear more brighter, and the atria, the left and the right atria, are increased in size, and echocardiography could demonstrate thickening of the left and the right myocardium, ventricular myocardium. The cardiac valves could also be thickened as in amyloidosis. ECG would show low QRS voltages, STT wave changes, and arrhythmias, and atrial fibrillation, and then left axis deviations, and then left bundle branch blocks, conduction defects. It's important to differentiate the restrictive cardiomyopathy from constrictive pericarditis. The left and the right atrial pressures and the ventricular pressures, filling pressures, would not be identical in restrictive cardiomyopathy, but in constrictive pericarditis, they would be identical. During catheterization, a biopsy sample would also help differentiate the two, and MRI can help differentiate, as in constrictive pericarditis, the thickness of the pericardium would be more than 5 mm in constrictive pericarditis. So MRI can be handy as well. But during catheterization, but in catheterization, the elevated right and the left ventricular filling pressures would reflect as a dip and plateau pattern in the pressure tracings. And that would also be pretty much seen in constrictive pericarditis. Um, the imaging studies can be utilized in looking at cases of sarcoid as a visualization of granulomas, inflammation, and edema. All can be appreciated with the help of MRI, and the PETs and the CTs can be utilized, um, and they are kind of useful diagnostically. Treatment wise, different conditions would require different kind of treatment, but mostly it's the congestive heart failure that needs to be taken care of, the control of the blood pressure, and utilization of diuretics, and then salt restriction. And for other underlying causes, as in sarcoid, utilization of glucocorticoid therapy, and for hemochromatosis, chelation therapy, and reduction of iron stores, basically, phlebotomy can be employed. For those having arrhythmias, one need to be careful utilizing drugs that kind of lead to arrhythmias. It can worsen the arrhythmias because of accumulation, and the placement of ICDs in this condition is very helpful. In eosinophilic cardiomyopathies, utilization of steroids and cytotoxic drugs may help. Um, so pretty much the underlying cause-wise treatment can be initiated.